Well, welcome everybody to today's Grand Rounds. I'd like to start by acknowledging the traditional custodians of the land on which we meet, the Ngunnawal people, and pay my respects to elders past, present and emerging. And I'd particularly like to acknowledge any Aboriginal and Torres Strait Islander peoples here with us today. We are very lucky to have Michael Chapman, who is a geriatrician and palliative care physician and the current Director of Palliative Care at Canberra Health Services and the chair of the Clinical Ethics Committee, to navigate a very difficult and timely topic, palliative care for older Australians after the Royal Commission, The Difficult Balance. Michael, welcome.
Thanks, Tim. Thanks for the opportunity to present today. I really welcome the chance to talk through, as Tim said, quite a difficult topic that we're all sort of facing as a community. Hopefully we can make some sense of it together. I'm going to talk through a number of different things today, which I won't belabor at this point, but a lot of this is focused on some thinking around responses to the Royal Commission and the challenges it poses for us. Just as a disclosure, I'm an investigator in several of the trials that I'll be talking about today, so apologies for a little bit of, flag waving on that sense. And also an acknowledgement that while I feel like I certainly have some expertise to contribute to this space, I'm not an expert in everything that's happening within aged care. I'm very conscious, in fact, that some of the things that I'm talking about today, there are likely other things happening in the ACT, other services, other teams that are contributing incredibly valuably. Apologies for not including that and for the limited scope of my knowledge. So why me? Within the Royal Commission, one of the things that the Royal Commission talked about when they were talking about aged care was the necessity for us to develop what they call the professionalised workforce in aged care. And I think what they were really referring to was clarifying and supporting care providers in aged care contexts who often are people who don't necessarily receive adequate remuneration, support or education on many different fronts. But there are different elements to this professionalised workforce, one could wonder. And perhaps someone like me, and a colleague of mine has coined this term a palliatrician, a geriatrician who's also a palliative care specialist, potentially is a sort of a newish kind of non-traditional voice that might be contributing to perhaps some of the thinking that we could extend towards how we're going to manage the challenges that our ageing population and our care for that ageing population kind of creates. But there's a lot of work to do. It's sort of understanding how these roles work together. And so again, I acknowledge my small piece of understanding that complex puzzle. I thought just to set the scene for talking about this today, I might start with a story. And I met a lady by the name of Jenny. It's not her name, but I met Jenny some time ago, earlier this year in Canberra Hospital. Jenny is an 80-year-old lady who'd been diagnosed with dementia about 5 years ago and lived on a farm with her husband, Charles. And they had pretty limited supports because they didn't need them prior to her diagnosis, and then because they weren't necessarily particularly available in the context they were living. They moved to an aged care facility when it felt like things were getting too much and her care needs were increasing, particularly because she had increasing distress in addition to her cognitive impairment. By the time I'd seen her, she'd been in hospital for about 4 months. And there was, in the context of her being in hospital, significant debility, increasing sort of require for functional support and lots of active symptoms. And the active symptoms were particularly a lot of distress, a lot of calling out, which unfortunately was now at the stage that there didn't seem to be a response that seemed satisfactory other than her being sedated more and more of the time, which was of significant distress to the family, feeling like this was the only option. It was unclear that leaving the hospital would ever be possible or right, but there was a clear and reasonable wish from a hospital perspective that if Jenny's care could be moved somewhere else safely, that maybe that was a good thing to do. And there was, Jenny was referred to palliative care within all of that because of a new focus on comfort for her as being now a central priority. In some way, interestingly, that seemingly hadn't been the priority all along, which clearly had been from the family. Jenny's story for me, unfortunately, isn't unique, and I'm sure many people around in this virtual and physical auditorium have heard lots of stories similar to them. And it raises all sorts of questions and challenges to me, none of which have easy answers, but one's, determining the start of what a palliative phase of care means for older people with complex issues, particularly for if they have dementia, determining the roles of different teams across sites, and within some kind of continuity of care for people who tend to move from different institutional environments, as we often do as we're aging. Caring for a network of people. For Jenny and for many other people like her, one of the prime or some of the prime recipients for care were not just Jenny, but the people around her, her family, who were really suffering as a result of her changes. And how do we care for that? And where does that happen? And who provides that kind of care? Maintaining a focus on dynamic goals in the sense that people's needs and their preferences often change, both patients and families, as their health need changes, particularly as we age, and providing complex care, which I already acknowledged. These challenges may not be unfamiliar to you, and they're certainly not unfamiliar to the aged care sector more broadly. And this slide here is just to highlight some of the issues that were raised during the Royal Commission. So the Royal Commission highlighted that as an ageing population that we have a growing ageing population, that we're with an increasing care needs, increasing complex health problems as people get older, and a decreasing carer population by virtue of the fact that more and more of us will be older and requiring that care. There's also a recognition that there's going to be an increasing requirement for palliative needs for people who have more and more complex care requirements because of their multiple comorbid conditions in this aging setting. There's care service challenges. Many of these are obvious, but includes obviously things about the challenges for providing care in different contexts, the challenge in the aged care sector of a small pool of big organisations providing care rather than a very distributed pool of smaller organisations. An increase in government spending required to maintain aged care, which is moving towards 4% of GDP and increasing now. And widely reported operating loss in facilities that the 2018-29 data, all of the big players felt that they were losing money for aged care involvement, despite the costs that clearly are passed on to the community from that kind of input. There's was and are disparate service models and standards, lack of obviously it's got a palliative care flavour because of my particular bias, but a lack of a single palliative care model in aged care settings, lots of different divides across jurisdictions and across healthcare settings, and the challenges of care provision across frequent separations, and a colossal care workforce needs, both in generating and having the care workforce needed to care for this huge population of people, but also to train them, to support them, and to make that care valuable and sustainable for them. The Royal Commission, I'm not sure how many people here read the report from the Royal Commission. I assume it wasn't many of us. It was a big document. Even the executive summary was pretty harrowing reading. However, I'm sure many of us actually saw media associated with the Royal Commission, which now seems to some of us, I think, probably a comfortably a long time ago, because we all had this thing called COVID that came along, and most of us got disinterested in the Royal Commission into aged care because we had all sorts of other things to worry about. But there are a lot of challenges raised during the Royal Commission. And just to give a little snapshot of them, there were particular issues to do with access to the systems itself, the care that people require, and particularly for people with disadvantages and vulnerabilities. Lots and lots of reports of substandard care with dreadful statistics of people, up to maybe 40% of people having concerns about the care that they were receiving, and a very, very significant and frequent reporting of abuse of various different types in the aged care setting. Issues to do with access, substandard care in complexity and in routine settings, and issues to do with systemic and complex issues to do with governance, remuneration, the focus and the models, and the need for innovation, none of which was at that time really at the level it should have been. The Royal Commission then provided 148 recommendations, which were very systematic at all levels, requiring change, and the changes were very, very significant. And there's 4 areas for immediate need that they highlighted, and I want to particularly focus on dementia care and palliative care because they're 2 things that are very close to my heart, and perhaps something that I've got, you know, some valid voice on those kinds of issues. So to me, what this we can sort of take from this up until now is that this is a really complicated problem, right? You know, that some of these issues that we've highlighted are clearly really difficult ones to solve, to do with the sort of volume of care requirement and just the sort of sheer statistics that we're working against. But I think, unfortunately, it's even kind of worse than that, that it's not just complicated, that this is a complex series of problems, a complex system that we're working within and against. And what I mean by that is that when we're talking about the experience of aging and health, we're not just talking about simple causal challenges in regards to disease and changing physiology. It's much more complex than that. It's to do with culture and value and society and all sorts of other things that play into how we experience and how we understand disease and what that means in terms of any kind of notion of what good living can be. That's true as well for care. You know, care and aged care in this context is, again, another complex system. There's a lot of different pieces and that contribute to that. It's not just as simple as saying, well, we'll provide more aged care. There's a lot more at stake than that, and a lot more influences that mean the problems are so big and difficult to solve. The flip side to that are there are more opportunities for us to engage with to try and actually do something meaningful. We don't just need to, you know, stop people from being older, for instance. You know, there's a lot of other things that we can do to actually try and improve aged care, even if it's actually a very, very big and challenging prospect. If we wanted to just, and I'm not going to bore anyone with a theoretical talk about systems thinking and complex adaptive systems, but if anyone's interested, these are some kind of key points here. That complex adaptive systems are communicative and dynamic, that they're responsive, that they relate to other things, they respond to events and stressors in ways that they self-determine, and they're also systems that affect systems. So in the sense that there are lots and lots of systems that make up our world, and they all have impacts on each other rather than being things that are completely distinct from each other. I'll give you an example. A way, if you wanted to think about the complexity, the complex system of aged care, is to acknowledge that the aged care system has a relationship with politics, right? Aged care affects politics, and politics affects the way aged care works. They're 2, one would imagine, quite separate things on one level, but they clearly have impacts on each other, and they can therefore impact, you know, what is good progress or some kind of meaningful outcome in aged care is within the political space. And clearly, you know, the Royal Commission was one kind of political response to a very complex problem. Again, just in interest of time, I'm only going to make one point here, but just to say that when you're talking about complex systems, it can all sound too bewildering and like, that's too hard, that's too many pieces, too much moving parts, that's, you know, way too hard. There's no way you can fix that. There's no way you can create change, but you can, okay? Introducing antibiotics to a person with an infection is a very simple introduction of a mechanism to improve a very, very complex system. But it creates a really great and meaningful outcome for that person, despite all the other things that are going on. The right thing at the right time can have a profound impact on a complex system, but also lots of things that are kind of perhaps the right thing that are all working in the same direction can also be meaningful. And the reason I make that point is because that's what the Commission has essentially endeavoured to do. We're not looking for a silver bullet that's going to fix things. We're trying to fix lots and lots and lots of things that could all be helpful. And I've produced a short list of things that are changing there right now. These are changes that are either in process or coming in the aged care space. And so even though perhaps many of us have kind of lost focus on the Aged Care Royal Commission, please don't think that that means that things aren't changing. There's lots of things that are happening right now. But it's also probably safe to say that it's a bit too early to say how many of these things have been as helpful as they need to be, because obviously change takes time and we probably need some more time to know. I'd also note that I think that there's a very significant prevalent worry about aged care within our community. And one of the perhaps unintended negative impacts of the Royal Commission was to really highlight how worried we should be about aged care without providing a really quick, easy fix to that. And so I think that worry is still with us and will be with us for some time. And obviously that's something we need to continue to work with. I'm going to shift now, if that's okay, with the time I've still got, to talk a little bit about there's two immediate needs, or two of those immediate needs that the Royal Commission identified. And I'm going to talk about dementia care and palliative care. Dementia. So again, dementia is a big problem. You know, visibly dementia now affects 400,000 people and 68% of all people in aged care facilities. It's the second leading cause of death now in Australia, and numbers are only expected to increase with a doubling of prevalence anticipated by 2058. Hidden elements of this are frequent, and there's significant underdiagnosis in dementia in older people, and limited recognition of the impact of dementia in younger age groups. And there are also hidden depths to dementia, which perhaps are sometimes not necessarily apparent to people. The dementia is understood in particular ways that sort of characterize it as a descent into some kind of monstrous or subhuman experience, which tends to increase the harms associated with the diagnosis. We assume and anticipate some kind of result of a diagnosis of dementia, which makes us really fear dementia as a society, but ultimately probably treat people with dementia in particular ways that actually makes dementia maybe a little bit worse than it absolutely needs to be. Oops, sorry, just going to move that chat thing if I can. Yep. And there's lots of different ways that we can sort of discern that. And I guess, one would be, how much people worry about dementia and how much they talk about it. But for me, as a person interested in the VAD space, voluntary assisted dying space, one could wonder if society's keen and prevalent interest in Australia of making sure that people with dementia get access to VAD as soon as possible is a result of how much people are worried about dementia and are worried about getting it. Because it's probably generally not people with dementia that are those people that are pushing that advocacy. Dementia also has hidden contributors, if I can get that. Oh, sorry, I've got that to stop working. Hidden contributors. It's not something that just results from neurobiological change. Dementia is, a result of a variety of different contributors that are, physical, social, communicative, cultural, things that contribute to that experience that aren't just the thing that changed within, different plaques or tau within our brain. And so as a consequence, there's a lot that goes on that actually contribute to the experience that we have. I guess another thing to acknowledge is that while dementia is very clearly something that people get sick of and die of and have a lot of symptoms from, and we clearly know that it should be a component, that palliative focus should be a component of dementia care. This isn't routine, unfortunately, at the moment. There was a great study, EAPC White study a number of years ago now, a Delphi study that highlighted a number of domains of the way a palliative approach to dementia care should work. And colleagues and I published a similar paper recently after the Royal Commission, looking at the sort of ways that could be understood in response to the Commission's findings here in Australia. And it really talked about this, these fairly routine kind of elements of palliative care that people like me often parrot on about the notion of early integration, multidisciplinary care, longitudinal care provision, anticipation of needs, and a holistic approach to provision of care for patients and for the people around them, and particularly support for caregivers that aren't specialists like staff and primary care providers. But as I said, that these are understood, but not necessarily things that result in routine care provision. And so the usual benchmarking approach in Australia, the Peacock service says that there's a very low utilisation of specialist palliative care for people with dementia is a primary concern in Australia, 5.1% compared to 61% of people who receive specialist palliative care who have a cancer diagnosis. This is despite the fact that we know there are lots and lots of people with dementia out there. And a needs-based approach to palliative care and specialist palliative care use seems to make sense, but again, is something I'll talk about a little bit more, but something that's still waiting for prime time a little bit. There are also really very specific challenges associated with dementia that I haven't acknowledged yet, and BPSD, behavioural and psychological symptoms of dementia, are one that really require some additional thought. Jenny, in the story I talked about before, was displaying evidence of BPSD and her calling out. And BPSD is not a single thing. BPSD is a high prevalence syndrome of a variety of different things, none of which we really understand perfectly in dementia. But it can include things like apathy, depression, anxiety, and a whole bunch of other things, including calling out. Importantly, it has very likely biological, psychological, social, and environmental contributors. It's not just something that's happening because of the dementia, a dementia symptom that requires an easy fix. It's more complex than that, and requires complex interventions likely to improve things. The challenge for that, unsurprisingly, is that BPSD is really difficult to manage. And honestly, we've got really limited evidence for the therapies we tend to use for it. Non-pharmacological therapies have relatively unclear efficacy, but are highly safe and are incredibly resource intensive. And so particularly in the acute hospital context, are not often available, even if they might be a good idea. And pharmacological things have unclear or poor efficacy based on our best evidence, and are not safe, definitively not safe, but are less resource intensive and therefore are easier to reach to. There's also complexity in regards to, the risk and benefits of what you do and when, and the challenge of where you provide care. And there's a frequent reach towards hospitals to provide care when things get tough, acknowledging that hospitals have more of most things than the aged care setting has. But people don't necessarily do better in hospitals with BPSD. In fact, they probably do worse. This is an even more complex and controversial space, but about what does care look like in dying with BPSD? And again, I'd maybe just highlight just the point that this is an emerging area of practice without a clear gold standard, but something it should be a case-by-case basis, and certainly that specialist palliative care would be very, very happy to work through in cases where best practice is unclear. And also note that as in Jenny's story, dementia affects everybody in the context of an acute hospital. Affecting acute hospitals is of clear interest to lots of hospitals, and people with dementia are more likely to need to come into hospital. Their admissions are longer with more complications. Their admissions mean more, and I mean that they both have implications for the person in terms of their prognostication. If a person comes into hospital with dementia, they're much more likely to die soon, they're much more likely to need readmission, but it's also associated with morbid changes for that person as well. They've got decreased function associated with needing to come into hospital and decreasing quality of life. It's a big deal for a person with dementia to need to come into hospital. But it's also the necessity for hospitalisation is affected by continuity planning and earlier identification of needs. We can do things about this. Hospitalisation isn't necessarily beneficial for people with dementia in many situations and can be avoidable with the right planning and preparation. But that's difficult to achieve, particularly all the complexities we've talked about already. I also just wanted to mention quickly about an often forgotten part of the dementia experience, which is the effect on carers. That people with dementia always rely on those around them. And a huge proportion of the people that are providing care are informal carers, people that are not paid to do this, but are doing it for a variety of different reasons, often because they're related to the person. 75% of community dwellers with dementia rely on informal care, and it's a huge and growing requirement. Care is meaningful, it's important, it's a process of creating identity and value. And so it's not just about to get someone to the toilet. Care is actually incredibly important. And we cannot undersell the value and the importance of it, but it costs carers to provide care. Carers have poorer health outcomes associated with and lower quality of life, and they're not well supported. The role is challenging and isolated, and generally speaking, clinical services who focus on providing care for a patient, not for the carer who might be caring for that patient, don't necessarily support carers perhaps the way that we could. Supporting, connecting and educating carers, though, can be helpful, and there are many steps towards trying to do that more holistically. And again, I'll talk about a little bit more in a sec. So I'm going to rush on, and hopefully people are keeping up. I'm sorry if I'm moving too quickly, but I'm going to talk now about the second immediate need, the immediate need for palliative care. And the Royal Commission made a number of, to me, incredibly heartening, if challenging, statements about palliative care. The Royal Commission said that palliative care is core business in aged care. It's a right, and it should be fair, equitable and non-discriminatory. It should include improved access to specialist services. It requires regular training of aged care staff for it to be provided well, and it should be reflected within quality standards. All of that I wholeheartedly agree with, and responding to it is a big challenge. Aged care does have a prognostic significance. A person going into an aged care setting from hospital, 20% of them are likely to die within 3 months. This is going into aged care has a significant impact for people, a significant meaning in terms of the care that they're likely to require, even if trajectories and needs may be variable for lots of people. It's also true, unfortunately, that we don't yet well understand, identify and anticipate the palliative needs of older people. We're relatively good at understanding things like needs associated with cancer, but if you start talking about common problems like frailty and multimorbidity, common in older people, which we know have a higher degree of physical and psychosocial needs, often similar to cancer, we're not particularly good at anticipating those things or really providing the best management. And unfortunately, from lots of studies, needs are often unmet, things are not identified, priorities are not established, and preferences and planning isn't done, which means that we're in this sort of situation where we have this awareness that older people have quite unique and comprehensive needs, but we don't necessarily have the plans in place to actually do something about it. Thankfully, there's movement afoot, and oh, sorry. I thought they were supposed to come up one at a time. Sorry, slide fail, animation fail. Apology about that. But anyway, this is a process that's being commenced now in aged care for screening and identifying palliative needs, run by a thing called the Palliative Aged Care Outcomes Program, which has been funded as a response to the Royal Commission. And I won't go through this except to say that this now provides a tool that aged care facilities can opt into of an approach for how their staff can use validated approaches to help identify the palliative needs of their residents, and a program for when they should be doing that and what they should be doing in response to it. A wonderful step forward that more and more aged care facilities, I hope, will take need of. That in itself, though, is not going to be enough. And, you know, who should respond to palliative needs? You know, the recommendations from the Royal Commission is that there needs to be increased support for primary care provision, both within aged care and within community primary care practice, but also increased needs to specialist support, all of which I completely agree with. But to you know, reframe an old adage in palliative care that palliative care is everybody's business, the challenge I think we're facing for care for older people is that it may be everybody's business, but it's nobody's responsibility. And we really need to make sure that we're all in this together to make sure that we're working in the same direction to improve things. And questions associated with that is, you know, how do we do more with stretched capacity already? How do we involve and engage existing supports rather than trying to supplant them? And how do, for instance, for the people in this audience, acute clinical services help and not hinder in this space? Conscious that, of course, we have perhaps slightly different needs from the aged care sector, but still a lot of interrelationship to try and make sure that we're providing care in the best way that we can. I suggest a really necessary way to think about this is the kind of idea of integrated care models. And these, just in short, I mean to say from that a model that integrates specialist services into existing care provision, which can be needs-led, provide care across transitions, provides support that's flexible and proactive and empowering, rather than something that takes away from the care that's being provided by the people that know a person best. As an example, I'd like to just briefly mention some work that colleagues and I did in the ACT around the development of palliative care needs rounds, which were a regular clinical meeting happening monthly, which took about 60 minutes, which involved the provision of clinical advice and education and the provision of proactive specialist palliative care review when it was determined as needed, based on this discussion between the palliative care expert and the aged care facility staff who were expert in the needs of the carers that they were, the patients that, residents that they were looking after, attended by staffs and clinicians, and provided for residents at risk of having palliative needs, identified by a similar process that I highlighted earlier. This is from a paper that we published looking at what a palliative care needs round involves. I'm very, very happy to share the references after it, but in the interest of time, I won't go through all of this now, but these are the kind of steps of what the conversation could include, which includes identification of needs and clarification of what they were, and also education provided to try and respond to them. And that led to a RCT that we did in the ACT a couple of years ago now, called the Inspired trial. And from that, we were able to demonstrate that this kind of approach, using this approach in the ACT, demonstrated a very significant reduction in the number of hospitalisations, decreased length of hospitalisations, I should say unnecessary hospitalisations, because clearly some people who are in aged care still need to go to hospital. The point is to try and stop that where it's appropriate to do so. Significant cost savings for the territory, improve quality of dying, improved knowledge about, improved assessment of the quality of the deaths that residents were having by staff in the facility, and improved staff feelings of their own capability to provide end-of-life care, and improvement in aged care pathway, aged care planning, advanced care planning completions, and more knowledge of and improvement of actually people dying where they want to. This has also been tested in a rural context and using virtual case conferencing models, and is now the basis for a number of different international programs looking at a similar intervention, and has now become standard of care at lots of places around Australia. One of the things, though, in closing, I just note that this wasn't, the Inspired trial and needs rounds did not have the same impact in each aged care facility, and perhaps we wouldn't be surprised about that. That the needs and context from some implementation science work that we did demonstrated or affected whether or not this was going to be a meaningful and helpful intervention for that particular context, which to me raises questions about how do we work with an influence context and mechanisms to improve care in the aged care setting. And I think key here is this notion perhaps of adaptable interventions. So things like needs rounds where there might be core elements of this that could be useful in varieties of different contexts that are used creatively to be able to be helpful based on that context. And also the notion of partnership or co-designed approaches, where if I had my time again, it would have been great for something like needs rounds to have been developed more formally with the community, with aged care facilities, with other people all contributing together to really own what that looked like and how it should be provided in the context that it was being utilised. So just in closing, I really appreciate your your patience with me whisking through a whole bunch of slides. I think that for me, a key requirement here is us to think more about how we influence, how we improved aged care. And in saying that palliative care for older Australians, and I would say that this is possible. This is possible. There's no element of this that is impossible. And not only is it possible, it's absolutely necessary. There is nothing we could do to avoid having to improve this. We absolutely have to do it. It's a complete moral requirement for us. The question then is an easy one. It's just how, you know, and how there's lots of different ways that we've already entertained through the Royal Commission to improve things, and I'm sure they'll be very effective. But there's almost certainly more to be done despite that. I think a key factor to kind of continue to remind ourselves is that older people are central to these aged care systems, and making sure that whatever we're doing is focused on their carers and communities' needs and preferences will almost certainly be effective and almost certainly be required. That working with systems on multiple levels is clearly important, and context will affect what's influential, and we should be conscious of that and dynamic in our approaches. But also that adaptable interventions can work. And if we can figure out ways that we can, as an acute care sector, work with other sectors and other colleagues to try and provide collaborative approaches to care that fit the context within which we're trying to provide it, as determined by the people who know that context best, I'm sure that things will get better and that we can have a key role in it. So I thank you so much for your patience. I really, really welcome any questions if anyone has them.
Well, thank you very much, Michael, and thank you for ending on an optimistic note in terms of the breadth of the discussion and the rather sobering points that you've highlighted. We've got a couple of minutes for questions. Nicole.
Thanks, Michael. I was thinking about your comments earlier in the talk about how most of us fear dementia, and I think this is, very true. That I think it is most people. It is the thing they really worry about at the end of their life: losing their faculties, losing the essence of themselves. And here we all are in a healthcare sector, and not all of our patients are cared for in geriatric units. And I do wonder about education around communication and how to care for these patients, because I think about all services have elderly patients with dementia on them, and I'm not sure that any of us are really confident in the best way to manage them. And this is in a society that talks so endlessly about communication, but what is the best way to deal with a patient who's calling out at night? What is the best way if the patient's really confused and they're on a whole other journey, they're confused about who's who, they're confused about where they are? Do you let them run with it? Do you keep bringing them back to here and now and reminding them and recentering them? What do you do when the patient has had a really agitated night? They're incredibly doped out in the morning, you can't wake them up, but should you get them up and do a lap of the ward and try and get them out of their sleep wakes up? And I guess I'm just saying that I think there's a real lack of communication or education. So even in healthcare providers, I'm not convinced that we know how to manage this optimally.
Sure. Really great question. Thanks, Nicole. And there's a lot in that in response. And I'd like to acknowledge again that while I, clearly have a voice here, that there are many others. I noticed Mal in the audience and Alex was here a little while ago, and there's lots of other people who should be commenting on this other than just me. But yeah, it's a really, really important space. I don't think any of us know as much as we could and should. There are also, we probably have gaps in our knowledge to know the sorts of resources and supports that are available to us, and things like Dementia Australia and Dementia Advisory Service are key things to know about if things were problematic and tricky. There are just on the point about communication, a bunch of colleagues and I have been talking a little bit about, the need for more communication skills training in the hospital, and maybe that's another thing that we could take on board as to a sort of an item for the wish list that we can incorporate into that. And there's also Mal and I and others are working on some education training to support staff, which is really sort of focused on the sort of more specific challenge of what supporting decision making looks like for people with dementia and for carers who are in hospital, but certainly embraces and includes how we talk about things and how we hold space with people with cognitive impairment. And again, happy to provide some feedback on that once that gets going, but hopefully that'll be helpful as well.
Can I just take, yes?
Oh, yeah, is it all right?
Please.
Sure, thanks. Thanks for the talk. I just had, I guess, 2 points I was wondering to shed light on. The first you mentioned enabling formal carers.
Yes.
Sort of supports. There are situations like that. And the second you mentioned about palliative and aged care. And I'm just reflecting on my own ethnicity.
Yeah.
Yeah. I know, especially multi-generational families, is a deeply sort of philosophical belief of like filial piety.
Yes.
Children are expected to look after their children, and what to do in situations where resources are limited. How do you navigate that sort of situation?
Yeah, they're amazing questions. So in terms of caring for carers in a general broad sense, so again, there's lots of people out there, and part of the challenge for us all perhaps is to not reinvent the wheel and to know that there are things that are available and supporting, and Dementia Australia is clearly one of them. Healthcare consumers have a variety of different supports available for people, and also sort of workshops, and Carers Australia likewise. While they're all hoping to develop more of a focus on dementia care, that's certainly in process. I'm involved in a RCT at the moment of a program called iSupport, which is specifically a program to support dementia carers in feeling more kind of empowered and supported and knowledgeable about what care looks like and how they can provide that in a way that's sustainable. Number of other people are involved in that as well. And so there are things out there that perhaps are hoping to become more sustained, routine, business as usual care, even if there's still things that are looking for their evidence at the moment. In terms of the cultural aspect of it, I think that's so important. And again, all of the things I've mentioned, including things like the multicultural, I always get this acronym wrong. I don't know if anyone's going to rush in and get it right for me, but the Multicultural Canberra Foundation? No, got it quite wrong, I'm sure. But anyway, that group as well is very, very interested in providing culturally specific kind of care and support for people. And again, all the things I've talked about already, including iSupport, are also developing more culturally nuanced, culturally specific approaches. As a person, as a clinician myself in caring for people, one of my governing priorities is to not make assumptions about anybody's culture or their belief system, and to let other people guide me on how that looks and how it should work for them. And I'm sure that's true for all of us and how we approach those things, and I'm sure that's often useful. I would just say that Manoj put in a comment, who's obviously the Director of Geriatric Service, put in a comment in the chat, I think in response to your question, Nicole, and has then said that if you don't mind if I read this out, a cognitive impairment coordinator, Shimi on 11A, is working with units across CHS to improve our understanding of managing patients with dementia. There are 4 modules recently made available on Atrium's CEO communication few weeks ago to improve our understanding about care of dementia patients. So more things available internally and more resources and education available out there for people who haven't touched base on them yet.
All right. Unfortunately, we've reached time. There are more questions online. I apologise about that, but I'd just like you to join with me thanking Michael for a very informative and